Welcome to our Caribbean and African Targeted Health Improvement Programme, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning. Nice to see you all. My name is Ngozi Ediosage. I'm a paediatrician. I work in Manchester. And I'm also one of the medical advisors for the Caribbean African Health Network. So welcome to this Saturday morning session. I'm delighted to introduce Dr. Itunu Johnson Shogbetun, who is a GP, but she specializes in women's health. And today she's going to address a really important topic, infertility, which can be really devastating because most people, most women and most families, when you're young, you dream of having a family and children. And when it gets to the stage where you now start to plan to have your family and it doesn't happen, it can be really, really distressing. So Dr. Itunu is going to talk to us today about some of the causes of infertility and some of the solutions. So welcome, and really looking forward to listening to your talk.
Hi, thank you for that lovely introduction, Dr. Ngozi. Thank you to you and Khan for having me here today. So I'm just going to share my screen now for my talk. Okay, so we're going to be talking today about infertility, in Black women, the silent health crisis. It's so just a bit about me. Dr. Ngozi already said I'm a GP. I specialize in women's health, menopause, and I'm also a health equity advocate. I'm actively engaged in multiple women's health organizations, and I also do equity, diversity, and inclusion advocacy at the Royal College of GPs, and also trying to not only raise the flag for health equality and equity, but also to support underrepresented GPs so that we have a more diverse workforce. Right, so we're going to start off with a story. So meet Jackie. So Jackie is a 32-year-old Black woman who is dealing with irregular periods and fertility concerns. She's been trying to conceive for over 2 years with no pregnancy, and she's really worried that she will never have children. And she's got friends who have similar concerns, and it's been quite scary. So what are the factors that are behind this, and what can we do about it? So reproductive health equity for Black women is really important. Now, we know that not all women want to have children, and that's, of course, their prerogative. Not every woman wants to have children. But for quite a number of women, that is something that, like Dr. Ngozi was saying, that they've wanted for most of their lives, and are, really looking forward to that point in time when they're in a position to have a baby. And when they have difficulty with that, it can be very, very challenging. But there are a unique set of challenges that create disparities for Black women in particular. And we'll be talking about some of this. It's also crucial to know that infertility rates amongst Black women are on the rise and actually now surpassing those of our white counterparts. So there's an urgent need to understand these issues, empower ourselves with knowledge, advocacy for our reproductive health, and address these disparities for better outcomes. So what is infertility? So the definition is the inability to achieve a pregnancy after 12 months of regular unprotected sexual intercourse. I think it's really important to highlight that. What is regular unprotected sexual intercourse? That is having sex 2 to 3 times a week. So a lot of people are trying, but they're aiming for particular times of the month and not having regular intercourse. And that can just increase anxiety, and it's not advisable actually. What we advise is regular unprotected intercourse, so sex 2 to 3 times a month, in order to say that you're actually trying. And I know that can be challenging with a lot of us with busy lifestyles and things like that. But, in order to say you're trying, you need to be really meeting that requirement. Now, infertility can affect both men and women. And I know we're focusing more on women today, but it's not just a female problem. And we'll be talking about that because male factors are really important. Now, there are many causes of infertility, as a successful pregnancy actually depends on a series of events. Now, dealing with infertility can be emotionally taxing, and there are often unique cultural and societal pressures that impact Black women specifically. Now, what are the things that need to happen, or the things that can cause problems with fertility? So ovulation problems. So this is when ovulation means when a woman is releasing an egg every month, and that egg is there waiting to be fertilized. But if the woman doesn't release an egg, and this can be caused by lots of different problems, including hormonal imbalances, things like polycystic ovarian syndrome can be a common cause of this, thyroid problems, and other things like if a woman is excessively stressed, or excessively exercising, or not eating sufficiently. So it's important that a woman ovulates and releases an egg, but then it's also important that the fallopian tube, which is the tube that connects the egg to the womb, is open and able to allow the sperm to travel, because the sperm is coming from the vagina up the womb, and it meets the egg usually in the fallopian tube. Now, if there's a blocked or damaged fallopian tube, that can prevent the sperm from reaching the egg and hinder the a fertilized egg's journey to the uterus. So things that can have caused this include pelvic inflammatory disease, endometriosis, or having had previous surgeries, or other types of infection. And so this is the reason why we say, it's really important to get sexually transmitted infections treated in a timely manner. And we should be doing regular sexual health checks, and getting things like that treated to reduce the risk of this. Now, there can also be problems in the womb. So when the egg is fertilized, so that's when the sperm meets the egg, it needs to implant in the womb. Now, if there's a problem in the womb, and there's a structural abnormality like fibroids or polyps, or other problems like adenomyosis, it can be difficult for the fertilized egg to implant and or for the developing embryo to grow, and that can cause a problem with fertility. Now, there's also sperm problems, and I said, males can be affected by this. So issues such as low sperm count, if the sperm is not moving properly, what we refer to as sperm motility, or abnormal sperm structure, and that can hinder fertilization as well. So if the sperm is abnormal in count, in its movement, or in the way it's structured, any of those things can cause a problem. So if there's a fertility issue, it is extremely important that the male gets checked and has a sperm test. Now, age is also a factor, and this is something that is difficult, sometimes feels politically incorrect, because I wouldn't want any woman to feel that pressure from age, but it's a biological fact that we can't escape. So we do have to provide accurate information. Age is a factor. As we get older, we have less egg numbers, because we're born with a finite number of eggs. When babies are born, female babies, they have a certain number of eggs, and that number from puberty drops, and then every time we release an egg every month, we are losing eggs. And so as we get older, that means that we have declining egg numbers, and in fact, even also quality. Now, the same thing can happen with men, but to a much lower extent. We know that men can keep their fertility for much, much longer than women can. And, even very old men can still successfully father a child. But sperm quality can also reduce as men get older. Okay, so now Black women have higher infertility rates than white women. We talked about this already. But despite this, Black women are less likely to use in vitro fertilization, also known as IVF, which has been a real game changer in fertility management. This data, it comes from the US, but 8% of Black women aged 25 to 44 seek medical assistance for pregnancy, compared to 15% of white women. And these disparities persist even when socioeconomic factors are considered. So even when we take into consideration the financial burdens of fertility treatment, we still see that Black women are seeking these treatments less, and they have a lower success rate compared to white women. And, there are cultural factors, societal barriers as well, and financial barriers to why Black women are less likely to pursue these fertility treatments. But there's also limited, accessible, scientifically backed information about infertility for Black women specifically, which could be addressed to improve treatment-seeking behavior. So again, we need to educate our population, and that's why we are doing things like this. Now, Black women tend to start periods earlier and have menopause earlier than white women, which means that their peak fertility period is shorter. So this is really important. And again, I'm not saying this to put pressure on women because there's already sufficient pressure on women. It's just fact that we need to just know that, for Black women, our peak fertility period tends to be when we're younger. And so the older we get, even more so than white women, we have increased risks of challenges or difficulty conceiving. And yeah, this is something that we need to factor in if we want families. Now, we also have there's certain conditions that could contribute to infertility. So fibroids, PCOS, and endometriosis. And these conditions affect Black women disproportionately. Black women have a higher prevalence of fibroids. We know that over 60% of Black women by their late 30s will have fibroids, and nearly 80% by age 50. And this can potentially impact fertility due to their size and location. Now, Black women's endometriosis diagnosis is often delayed and lags 2.5 years behind their white counterparts. And this means that we're undergoing surgery less often with treatment delayed and higher post-surgery risk when we do have surgical treatment. And we also know that polycystic ovarian syndrome, PCOS, is more severe in Black women and has a lot of the other physical symptoms, so things like insulin resistance, obesity risks, and heart disease risks, and that can also make pregnancy to be more difficult, in addition to the struggles with getting pregnant in the first place. Now, Black women often experience what we call medical gaslighting or healthcare dismissal for their symptoms. And this is not just for PCOS, but for all these problems, fibroids and endometriosis. But in PCOS in particular, a lot of the time it's focused on, oh, you just need to lose weight, but not thinking about actually how the condition is contributing to the weight loss, and directed advice on how they can actually lose weight given the health condition. Now, Black women also have a higher incidence of hysterectomies. So often when other treatments can be provided, for example, with fibroids, there's a procedure called a myomectomy to remove the fibroids. We know that Black women are often offered hysterectomy, which is removal of the womb, which obviously renders a woman immediately infertile, even during childbearing years. And again, this is something that needs to be challenged. And with women having more knowledge, then they would be able to understand that there might be options that can be discussed. Okay, so when thinking about, why is it so common, these are other factors. So tubal defects, I spoke about the fallopian tube and that they can be blocked or scarred, and we see that Black women have a higher occurrence of these issues. So again, our knowledge of sexual health and seeking regular sexual health screens to make sure that we're not having sexually transmitted infections that haven't been treated that can cause problems in the long term. And then again, there's some evidence that Black males are more likely to have poor sperm quality, and this is for a variety of reasons, but this can also impact fertility rates. And then again, vitamin D deficiency. So that's more prevalent in Black individuals because of our darker skin tone, and melatonin doesn't allow sufficient absorption. And so when we live in temperate climates like the UK and parts of the US and in Europe, that can impact our fertility, as it helps with egg and sperm health and a healthy pregnancy. Now, we cannot not talk about stress and mental health. So minority stress, which is stress that Black women and men experience because of the difficulty existing in spaces where there is systemic racism and systemic inequalities. But there's also the added societal stresses that women in general go through, and this can be exponential for Black women as well. There's also challenges of finding a partner. We know that Black women often struggle with finding a partner, and we have obviously there are some women that don't want partners, but we have a lot of Black women who are still single, who are who would like a partner but have struggled to find them, and that can lead to stress. And then there can be family pressures. We know in a lot of our cultures there's sort of pressure to marry, especially in African cultures, and women can feel under, they might want it themselves but not having it, and then family pressures then compound that, and then there's also societal pressures, and this can all impact mental health, and further impact fertility outcomes. And then there's also the disparities in access to quality healthcare and infertility treatments, which disproportionately affect Black women, that limit their options for fertility care. So it's a whole host of things, but those were a lot of slides, a lot of information. So I've kind of tried to summarize that in this slide to say that we have a shorter fertile window, and that's important to know. So early periods and early menopause limit our number of prime conception years. And so this is important for us to know. We also have higher risk of the diseases that complicate fertility. So fibroids, PCOS, and endometriosis, for example, and they're often underdiagnosed and treated less effectively. And then also we have unnecessary surgery, so higher rates of hysterectomies, even when alternatives exist. But again, there are even with that, looking for treatment, we are not seeking treatment sufficiently, and this gap remains even when we consider socioeconomic factors, which are a big issue. We know that is a big issue, but even when we take that out, there's still cultural and societal barriers. There is limited access to information on infertility and access to culturally competent care for Black women, and then there's lower IVF success rates as well. Okay, so there is also cultural impact, and I think it's really important to talk about this, especially in African cultures. So often there's a lot of pressure from parents or in-laws. I know that obviously the mother-in-law is one particular relationship that has often been dramatized in a lot of African plays, putting pressure on women when they're struggling with infertility. So I personally have been through infertility myself, and have had to go through the IVF process. So I actually understand this from both the professional standpoint, but also from a personal lived experience standpoint. I mean, to be fair to my mother-in-law, she didn't actually put a lot of pressure on me, but in fact, she actually never mentioned it. But there's a lot of prayers, and it's not just, where I used to dread, I'm from Nigeria, and my parental heritage is from Nigeria. I used to dread going home because literally as soon as I arrived, people would stare at my stomach, and some would even touch my stomach and say, is there anything there? Or are you these career women? I remember time is ticking and not realizing that this is something that is causing me immense heartache, and all the, people praying, by God's grace, this time next year, we'll see your baby. I mean, it was all like, I know a lot of it comes from love or from a place of love. Not all, but some of it is people not minding their business. But a lot of it comes from a place of love. But it was very, very challenging to handle. And so, I didn't feel comfortable enough to share with a lot of these people about the infertility struggle that I was going through. So, and their approach made it even more that you just wanted to be silent. So there's that, feeling of shame and inadequacy. And I certainly know what that feels like, to feel inadequate and feel like your body is failing you. I remember those years where every month it would feel like a miscarriage when my period came, because I was hoping, I would have so many pregnancy tests. I'll do them secretly. I would even hide them from my husband, because I wouldn't want to talk about it. And, it was a very challenging time, and it can put strain on relationships as well. And we know that communication and openness can help bring things into the spotlight and help create relief. And so, finding a group of women that understood what I was going through was really helpful. And finding ways to communicate with my partner better was really helpful. But it can lead to isolation and communication issues in a relationship, especially when people might handle it differently. Men and women, the way they handle infertility can be very different, and it can really strain those relationships. And of course, also, even in same-sex relationships with a fertility struggle, it can also cause challenges. Now, spiritual and cultural beliefs. So again, certain religious beliefs might challenge things like IVF, or can you really do that? And that's obviously a personal choice for an individual to make, but this is something that, we see in our communities, or, infertility might be, quote unquote, that's how God wants it. And not thinking about there's treatment, and it's just it's a health condition like any other health condition. But again, you have to understand where people are coming from. If that's their spiritual or cultural belief, I think we can challenge it in a non-judgmental manner. But these things impact women. And then again, it's really important to have that culturally competent mental health support, and that lack of access to it can really worsen the impact of infertility. Okay, so what are the treatment options? I think it's really important to know that a lifestyle is very important. So healthy habits like eating healthily, so good diet, regular physical activity, and being a healthy weight. So being overweight can really impact fertility negatively. And so, it's important to be a healthy weight. And I know certain conditions make that more of a struggle. And there are things that can be done to help with that. And I'm never about weight shaming, because it's really important that we approach weight management in a way that is helpful and not harmful. So, but it's a part of the management process. Stress management, that's really important, because stress is really almost an enemy of fertility. And we often see that when people's stress reduces, they're much more likely to conceive. And of course, avoiding harmful substances like cigarette smoking and heavy alcohol use are also important. Now, medications, so there are hormonal drugs that can be used under direction of a gynecologist to stimulate ovulation, particularly for women who have polycystic ovarian syndrome and are not ovulating. But then, what has been a game changer is really in vitro fertilization, so IVF. And for people with sperm issues, there is even ICSI, which is when the sperm can be injected directly into the egg to even heighten results for IVF. And we know that embryos can be frozen and used at a later date. So this has really been a game changer. But again, it's much more effective when done younger. And so when it's done older, firstly, it's more difficult to get good quality eggs, and the process is just much more complicated. So, yes, this is a really important treatment option. But again, sometimes we need to do surgery to correct the problems like endometriosis, fibroids, or blocked fallopian tubes in surgical procedures to correct these if they are the cause of the underlying fertility problem. Now, there are some women who no longer have eggs or have some conditions that mean that they don't have eggs, and so donor eggs or sperm or even embryos may be needed in order to have a baby. So what can we do about it? So I think education and awareness is really, really important. And when we talk about this, we talk about something like this where women are getting information about fertility and what they need to do about their body, do for themselves, awareness of health conditions that might impact fertility, so that when they're having conversations with healthcare professionals, they are expressing their concerns in a way that's articulate, and so that it can be more effective, and so that their concerns can be validated. For example, women knowing about polycystic ovarian syndrome and endometriosis and all these other conditions that can affect fertility. Regular checkups as needed can also be really helpful, especially if you haven't had you've been trying for a year. You should go to your GP and have investigations, including the sperm check. A healthy lifestyle we've already talked about, which is really important. But know your own body as well. If you've noticed a change in your menstrual cycle, so keep an eye on these things. Take ownership for your own body. So keep an eye on your menstrual cycle. If you notice that there's a pattern or a problem, if you notice bleeding in between periods, your periods are getting heavier or more painful, any of these things could indicate an underlying problem. And then you need to flag that up to a healthcare professional, but also advocate for yourself. So it's really important. And that ties in with education. So when you know more, then you can advocate for yourself. But as I always say to women, be persistent, because often we know that we get medical gaslighting as Black women. I've even experienced it, even though I'm a doctor, you know, in my own infertility journey. I was eventually very grateful to find a team that were culturally competent, but it took a while. I literally, I think I saw about 3 different teams for IVF treatment before I finally went with the team that helped me get my baby. And so the first few teams, it was just really a nightmare. So again, you know, advocating for yourself, doing research to find out whether, you know, I wish I had done a bit more research before and found out a bit more about the process of eligibility for IVF treatment, because different areas have different eligibility, and how long the waiting list is. All of those things you need to know, and then you also need to plan financially. If you are in a position where you can you're not eligible for IVF treatment on the NHS, then you need to plan financially if you wanted to have IVF treatment, for how you're going to afford it, because it can be quite expensive. And some people end up going to countries like Cyprus or where it can be a little bit cheaper. Some people even go back to Africa, where there are quite a few clinics, or the Caribbean, where there are quite a few clinics that are good. So again, doing your research, planning financially, building support networks. There are online support networks, but again, within your friend and family network, have trusted friends that you can share with. This journey is very challenging and can be very painful. I know this from my own personal experience. So having people that you can talk to who can support you is really, really important. And that ties in again with managing stress. So doing things that you know relieve you. So I often talk about spending time in nature, hobbies and things that can help take your mind off the stress of things. Having fun. So even whilst you're going through the pressure of a fertility journey, it's important to remember that you're a human being, and it's, you know, you should allow yourself to have fun and not let it be all encompassing. And you know, culturally competent and holistic care cannot be understated. It's really important that healthcare providers that and I know this can be a challenge to find, so I'm not, you know, in any way, this is something that as healthcare providers we're working on advocating for improved culturally competent care from our colleagues. And that's part of the work we're doing because it's so important. And holistic care as well. So looking at you as a human being, the whole totality of you, your physical and mental health, and also the things that your social factors, what's going on in your life, that kind of care, a care that's 360 degrees, that's the kind of quality of care that one should aim for, because you deserve that. And then finally, I think as a Black community, it's important for us to understand how to advocate for our reproductive health needs. So things like health literacy, community support, again, advocating for access to access to care, so eligibility, but also culturally competent care, so that, and that's part of educating healthcare professionals themselves about cultural variations and things that impact our community. Research and data is crucial, and we need more research and more data on this issue on Black women globally, but also in the UK. Mental health support, so we have to have better facilities to support women going through this. Representation is so important, and that's from patients, representatives in health communities and policy makers. We need that representation, but also representation in terms of the medical professionals having a diversity of representation, so that patients can see a diverse group of clinicians, and that means that when there's more diversity within the healthcare profession, it means we're able to provide better quality care to the diverse communities that we serve. And then patient advocacy groups as well. So it's really important that you, if you feel strongly that you could join advocacy groups to, you know, that raise awareness and literally go to governmental organizations to talk about health disparities, reproductive health disparities in Black women, and try and bring change about. Okay, so I'm going to stop there. Thank you for listening. Any questions?
Dr. Tunu, that was amazing. I feel like I want to give you a clap. That was really, really fantastic. Thank you so much for sharing your personal story, because I know it connects. There'll be lots of people who have listened to this and think, well, she's a doctor, she knows what she's about. And the fact that you've shared your own personal story to say, so people feel, one, they're not alone, but also the advice that was given as well. And we've got lots of questions in the chat. You know, this is on our social media platforms as well. And so we've had questions coming from there. But thank you so much for that talk. It was excellent, fantastic. And I think that's borne out by the number of comments we've had. So I'm going to make a start with some of the questions we've had. So one of the questions is, are Black women seeking assistance less, or is it inequity based in GP referrals? Because, you know, you talked about the fact that there were less people accessing fertility treatments. And also, this question comes from: is it because something like the BMI criteria mean that less people are likely to be accepted for that? So what would you say about that?
I think it's a mixture.
Yeah.
I think it's a mixture. Of course, we know that things like BMI criteria do not favor us. And I really hate using BMI because it's such a non-nuanced way of judging someone's physicality. But it is what we have, or what, and a lot of the health boards use that as a criteria for referrals. So it can be an obstacle. But I think also a lot of Black women are not seeking the help as well. So I think it's a multi. And then when they do get there, there's a lot of medical gaslighting. There's a lot of, oh, you're overweight, and there's a lot of that as well. So I think it's both.
Okay. The other thing you talked about was that the fact that you're born with a finite number of eggs, and so they will run out at some stage. That's just factual. And there are some people who are seeking help because they're infertile, but there are some people who would like to be in the position to have babies, but they just haven't met the right person. So what would you say to a 30-year-old now who hasn't met anybody and he's worried about this finite number of eggs? When is the optimal time to think about egg freezing?
So I think that honestly, the younger, the better. So if you haven't met a partner by 30 and you're a Black woman, if you can afford it, I would say consider freezing your eggs. Obviously, it's not the panacea. We know that. So sometimes in the egg freezing process, firstly, the process can be quite involved. It can be quite expensive. And then we know that when you come on the other side, because you still have to freeze the eggs, get eggs of good quality in order to use that in the fertility process, that can also be a challenge. But it's what we've got at the moment to try and preserve fertility. And I think that that's something to really consider, because our egg quality, as I explained, because we have our periods earlier generally and menopause is earlier, for many of us, our peak fertility really starts to drop dramatically over the age. I mean, for a lot of white women, we say it drops dramatically over 35. For us, we think it's even a little earlier than that. Although we don't have, again, there's not enough research to say exactly when, but we know that, if you're 30 and I would say, consider if you can afford it. A lot of workplaces now pay for it as well. So you can ask your work, would you consider sponsoring me for this as well?
I'm glad you raised this and you said that, because you're a GP, so you'll see people coming to you for infertility. I'm married to a gynecologist, so he sees the other end of this, and he usually sees people when it's much too late to advise them about, they've gone through lots and lots of advice and therapies, and they're coming to the end of their journey. So really, the egg freezing, he always says, if he meets anybody, you've got to 30, it gives you choices. So it
Yes,
might be that you meet somebody and it all goes swimmingly, that's fine. But it gives you choices if you freeze your
absolutely.
eggs at 30, because you've got a backup plan. So I think if you're listening, if you take home one message, that's one that you can share with family and friends.
Absolutely. It's so sad. I've heard quite a few people be like, I wish I had known about egg freezing, because by the time they go, oh, sorry, your AMH is low and your eggs, we can't really harvest good quality eggs. And they're like, oh, I wish I had known. And this is really something that we need to be sharing with our community.
How easy is it to get? Because the AMH test that you just referred to is a test of your fertility reserves, is it? What
Yeah,
test is that?
yes, it
So
is.
how easy is it to get? So if, let's say, I was 30 now, I'm thinking, well, maybe I can't afford it, but I want to know about my fertility reserves. Would be an what is it?
AMH, AMH.
AMH test, an AMH test that would went into my GP. Would I be able to get access to that?
Most GPs will probably say no because it's a specialist test. And often, I mean, you might get your GP that will agree. And again, it depends on whether it's even on the GP panel, because we have sometimes limited panels of blood tests that we can offer within a GP surgery. You may be able to get it done privately, so you have like a limited consultation with sometimes you can just see someone for again, these things I'm not trying to minimize the cost, but just a focused appointment about fertility and an AMH. So you might all in could be about 300 or 350 pounds with the testing. I'm just giving an estimate. But these things are expensive, and I know that quite a few people might not be able to afford it. But for the burgeoning group of women who feel, I have options, I want to know my options, then you could, and then a lot of the fertility clinics who, when you're considering egg freezing, offer that initial consultation and would usually offer the AMH. A lot of people do it alongside an ultrasound as well, to just look at the ovaries and make sure that things are all right there.
Yeah, no, I was saying it in the context of, because it's a test that tells you about fertility. So again, it's options. So if you did that and it was, you saw that the numbers weren't right, you might consider egg freezing. But if you were great, you might think, okay, I've got another couple of years to look for a partner.
Yeah. So it would be really helpful. But the problem is, because it's not a perfect test, it hasn't come into general practice yet as something that we can offer. It's something that is considered to be a specialist investigation. Whether that might change in the future, and having these sorts of conversations might be helpful to think about, okay, is there something that we can use to empower our patients with more information? And I think it's certainly something that should be considered. But again, GPs need to have the knowledge and skill to be able to interpret the test, and not some GPs might not have that. And again, as GPs, we have certain things that we are trained on, and then certain things that are considered to be a specialist remit. Obviously, as a women's health GP, you have that knowledge because you've upskilled in that area. So, and we have loads of women's health GPs around. So again, it may be something that you might need to see a women's health GP for.
Okay. Yeah, I think it was, and there's another question that's very related to this, and I think after this, I think we'll move on to something else. It was about a fertility check. Could you walk into a GP and say, look, I'm considering starting a family, I just want a fertility check?
Right. So basically, that's difficult. They're going to give you preconception advice. So there is preconception advice, about taking folic acid, taking vitamin D, foods to avoid while trying to be pregnant, avoid alcohol, those sorts of advice. But it's unlikely that they will do any investigations until you have tried for a year, because that's what the guidance or guidelines say. So again, if you want to get it done on the NHS, they need to know that you've been trying for a year. So again, that's important to know, if that makes sense.
Okay.
Because yeah, it's they won't investigate you until you say you've been trying for a year.
Okay. So yeah, no, it's interesting what you say about stress as well, because a number of people I meet who've had IVF, they have their first baby IVF, naturally for the second baby because the stress is gone.
Yes, it's very common. Stress is an enemy of fertility.
Are there any foods that you feel that can recommend that can impact on fertility, either positively or negatively?
Right.
Lifestyle and making sure you're healthy. What about diet?
So eating healthily, so rainbow colored food, making sure that you're eating whole grain carbohydrates, lean proteins, and lots of fruits and vegetables. Those are very, very important. Now, traditionally, they used to say, oh, yams increase fertility. And there is some truth to that, because yams contain...
And weight. Increase fertility and increase your weight as well, isn't it?
But please don't be eating lots of pounded yam and saying, oh, I want to improve my fertility, because you will gain weight, and that will be not helpful. But there was there was some research done into because there's a very high preponderance of twin pregnancies in certain parts of Nigeria and the southeast of Nigeria, and they thought it was associated with the yams that we eat. But that's just yeah. But as Dr. Ngozi said, please. I didn't say be eating yam every day, and then you say, look, I'm overweight because Dr. Johnson said that.
There's a question I've received personally about someone who has issues but is looking for a sort of safe space to connect with people who've got from a similar background who are going through the same issues. You know of any advocacy groups that they could join?
I should have actually looked this up, but I can prepare. If that person sends me an email, so just send an email to itunujohnson@gmail.com. I'll send you some information. And like, I know how hard it was. I didn't necessarily join any specific support groups, but my friends were just such a source of support and encouragement. But I will look for you. I eventually ended up having a miscarriage as well, and so at that point, I used Tommy's, which is like the miscarriage support group, because that I found even more difficult. My first IVF pregnancy was a twin pregnancy that I lost at 22 weeks. So after that, I turned to Tommy's. So sorry, I should have actually looked that up.
Fine.
I will get back to you on that.
We usually provide additional information at the
okay.
Send it out. That is 22 weeks. I'm a neonatologist. So after premature babies, so 22 weeks, you're almost there.
I know. I literally I begged. I said, would you consider? But they said it was too early.
Too early. Yeah, 22 weeks is early. Yeah, so there's a question about the impact of chemicals, including things like hair relaxers on fertility. Yeah, I see a lot of this where people say that it's related to fibroids, hair relaxers, hair creams. I don't know how true it is.
So there is certainly an association between hair relaxers and fibroids, increased risk of fibroids. I think we need to be careful. Thank you to everyone that's saying in the chat about my loss. I really appreciate that. And I think this is part of why we share our stories and share as a community, because just like all of you, I'm a human being. Even though I'm a doctor, I'm not immune to the pressures that Black women face in their lives. Sorry, back to the question. We have to really be questioning why we put these chemicals in our hair. And what we're trying to conform to. I'm not trying to make any judgments, but there is evidence that some of these chemicals can do us harm in our health. And so, that association has been made. It is true, in particular with fibroids. And so if you can avoid using relaxers on your hair, please do, especially for young children. Please don't do that.
Yeah. There's a question about mild IVF versus traditional IVF. This is not something I'm familiar with.
I'm not quite sure what they mean by that.
So what are your thoughts on mild IVF versus traditional IVF?
If the person can clarify what they mean by mild IVF, then I may be able to help with the question. I mean, obviously, with the IVF process, there's lots of different ways in which, it can be done. So I mentioned about the traditional where, the sperm is just allowed to join with the egg, and then the embryos that fertilize are implanted back, and the rest are frozen. And then there's ICSI, where the the sperm is directly injected into the egg, and that's usually used for people with some kind of sperm abnormality. And then you can have IVF where it's immediate. So when when the embryos are formed, you give it a few days and then you go back and have the implantation within the same cycle, or the embryos can be frozen to be used at a later time. But there's a lot of things out there about treatments that you can use before IVF. So
Oh, you're saying
right.
it's a protocol. I think as you say, there are
Okay.
lots of protocols and lots of
So there are lots of different protocols, and I'm not an IVF specialist myself, so I'm not going to be able to tell you about the distinctions between the different protocols. I mean, I've been through it myself, and I know that obviously there's the risk of ovarian hyperstimulation syndrome. So they can vary the dose that they give in order to try and prevent that. And particularly for women with polycystic ovarian syndrome, that can be done. Say, for example, I was given the lower dose initially, but it didn't work. And so they had to then change it to the normal dose, and then it worked.
How does previous abortions affect future fertility issues? And do you think there's a different impact for this on Black women versus white women?
I think that, one just needs to think about if the abortion was done in a clinic that is reputable, then obviously there's slight increased risk when you've had instrumentation. And again, it depends. What is it, medical abortion or surgical abortion? So a medical abortion where the person didn't need any instrumentation should probably bode less risk for the future. These risks are very small. Generally speaking, many people who have had abortions go on to have successful pregnancies. And I think there's a myth, it's one of the cultural myths that we have in that, maybe she's not got pregnant because she had abortions in the past. And I really would like to challenge her and say that that's not, yes, instrumentation of the womb can cause slight increased risk of problems with conceiving in the future, but it's only very small and most women are fine. But if you have had abortion in a way that wasn't regulated, then that can come with a lot of risk and harm and cause problems. But we also have to think about, if you've had unprotected sex or that has led to an unwanted pregnancy, have you also picked up a sexually transmitted infection? And that's another thing to be aware of, because I was really trying to emphasize that as Black women, we need to be making sure we're getting regular sexual health screens and practicing safe sex, because those untreated sexual health infections can cause problems with scarring and tubal problems, and that can lead to increased fertility problems. So we did see that Black women are more likely to have these tubal blockages, but I think this has to do with sexual health issues that may be associated with not practicing safe sex as much, or using, our engagement with contraception services is also less than the Caucasian population. And this is something that needs to change. And a lot of work is going, because we need to be practicing safe sex. We need to be using contraception when we want to, when we don't want pregnancies, to prevent unwanted pregnancies. And abortion, should be a last resort. But of course, I know that it's an option for women when, things happen and even contraception fails. So you shouldn't feel judged or feel like because you've had an abortion that, that's necessarily going to impact your fertility.
I liked a lot of the personal stories you shared about, going back home and well-meaning people just checking and perhaps touching your tummy. I remember a friend of mine saying that she just got married and she was not feeling too well, and she went to see her mother-in-law, and her mother-in-law said something like, "I hope send a better sickness," So, yeah.
Exactly. Those
Yeah.
kind of comments. Oh, she's not feeling well. Oh, okay, we know.
Yes. Um, But it also comes out, there's a sort of religious element to it. So I've had a couple of questions on, someone said that she was told that when she couldn't conceive, that it may be a curse for her particularly, and that she's been told that, and there's another question about that if you can't conceive, there's a reason for it, that maybe you would have had you might have had babies with genetic issues, and so actually you just need to suck it up, which I have issues with that. And there's a second question, I'm going to ask all of them together because they're related, about religion, and that if God really, if you're praying, if you've got the right connections with God and you're praying for something, it should happen. And that intervening with donor IVF perhaps is not, you should just wait for what God has for you. So I'd just like to get your views on that.
So I've had people say these things to me personally as well. So I definitely understand the challenges we have in our community. Saying that, someone is cursed, these are very strong words, would they say you're cursed if you have high blood pressure? Would they say you're cursed? I mean, they might actually. Yeah. Given our culture, in our culture, in our culture, they might. So, what I'm saying is, it's a health condition like any other health condition. You are not cursed. The fact that you have a challenge, I mean, I think this is where our religious, especially African, I think there's also an element of it in the Caribbean community, but it's probably more prevalent in the African communities, about this idea of, you must have done something bad for bad things to happen to you. And I even remember, not even just, with the fertility struggle, even when I lost the babies, there were comments like that as well. And it can be really hurtful, I'm not going to lie, can cause quite a bit of pain, but I think you just need to know what you know, and this is why it's good to educate yourself and know, and also get support from other people. And this is why these sorts of forums are really important for us to share stories. You are not cursed. If you need treatment, please get the treatment you need. And I'm not saying that the treatment is perfect. We know that, even with the best, even in the best hands, IVF success rates are still around 45%. So by no way, I feel, blessed that, I was eventually able to have my son. And I still only have the one child, and I still have people coming to me saying, oh, you only have one child, you should have two. I know a lot of, I shouldn't have said that in that tone. I know a lot of it comes from a place of love, but they don't know how hard the journey and the story has been. So I wouldn't take those, I would challenge those views if you feel able to. If not, know what you know in your heart and just keep it moving and get the support that you need to deal with that hurt. When it comes to saying that women should just accept, if you've prayed and it's not happened, then that must be God's will. I would challenge that. The Bible even says faith without work is dead. I think that how we interpret faith is different. I'm not in any place to judge your interpretation of your faith, but I would say that from my understanding and my interpretation of the Bible, there's nothing that would say that getting treatment for a health condition is not a good thing to do. But again, our interpretations are different. But I would say, please don't put more. We already have so much weight on ourselves as Black women. Why do we go and then start lifting up additional weights to put on ourselves? So please just go with what your own heart. If your own heart doesn't feel like there's anything wrong with getting help, just go with that.
Absolutely. And I think sometimes people are looking for support to get extra help. And one of the ways I was approached it was that for many of these treatments, these are God gave us that knowledge.
Exactly.
This is knowledge that I feel has come from God. So you all have to approach it in your own way. But I completely reiterate what Dr. Itunu has said about it not being a curse. That's just such an awful thing to say to somebody. But also you have to think about how the recipient of that information feels. And you just have to reject things like that. So I hope what she said today has helped.
Yeah, as someone has just raised a comment about the fact that men are participants. I don't know if you heard the early part of my talk, but I really highlighted that fertility is not a female problem alone. It's a male and female problem. And males can have problems with their sperm. There's a lot of pressure on women. If a couple is going through fertility problems, it's a couple going through it. I know culturally we put a lot of pressure on the women, and I think that needs to change. But again, I also understand that it's the woman's body that has the, periods every month when there's the loss. It's her that has to go through the cyclical changes. So the woman may feel it more in the day-to-day. It's her that will do the pregnancy test that's negative. And I know because I've been there, So again, the men, in my own experience, may not understand those fine details in the way that we understand it. But again, it's a couple problem, and we should really be pushing back from trying to make it into a woman's problem.
I completely agree. But also I think it's really hits men hard when you go for that consultation and you find out that perhaps the underlying cause of the infertility is from the male partner. That's really difficult for some men to deal with. Now, I would hope that women here that have that issue are also supporting their partners, because
That's right.
it's really difficult. It's really difficult.
Especially because men have that feeling of, it really sometimes challenges their own concept of manhood and can be very devastating. And so that may then mean that they don't want to talk about it or get involved. And they, again, it's really important, as you say, to find that support for them. And actually, it's relatively common to have some kind of abnormality.
Very, very common.
So again, as having a minor abnormality with the sperm count, or even with the woman, like having, doesn't necessarily mean that you can't get pregnant naturally. Sometimes it means that you just need that additional help. Or sometimes it means that you have to go through a different process. But sometimes men, obviously, when they have, like zero sperm count, that can be really devastating for them.
It can. I remember listening to, there's a poet, Benjamin Zephaniah. He died recently, and he had male infertility, and he was very open and about speaking up about it to try and encourage men to get tested and help to deal with that problem. He was a fascinating speaker when I heard him. I think there's one more. We've got about 3 minutes left, so just something else I wanted to touch on. There's been some personal questions to me about this. It's about egg donation and gamete donation and fertility problems using that. Very often, because I'm a neonatologist, I'm seeing older and older women, so people in their 50s, having children due to egg donation. Is there an upper age limit to egg donation, do you know?
So
Or receiving an egg. So I think so. Egg donation, you can't donate if there are no eggs, I suppose. But receiving egg donation.
I think that it will depend on whether the woman is healthy enough to carry a pregnancy. So obviously we've heard of stories of women in their 60s even with an egg donation carrying a baby. But different clinics will have their own different criteria and what they consider to be a cutoff. Because you have to remember that pregnancy is a high risk issue the older you get as well. So for some people, they might consider it after a certain age, it can become even more high risk. And so it might not be considered to be safe. And therefore, things like surrogacy may be considered in those settings. So I wouldn't want to say a specific age because it's dependent on clinics. And again, it's dependent on the individual and their health background and things like that. But I would say that it's something that would be thought of with caution over 55, with significant caution.
Oh wow, over 55, that's a lot. I'm surprised it's that high. But I have to say, I haven't seen anybody personally come through, but I've seen.
No, I mean, a lot of the time, over 50, that is, but I'm just saying that when you think about all the risks and things like that, but women have different stories and journeys and things like that. And you don't want to
go and get a consultation, I think, is the thing to do.
Yeah, exactly. We wouldn't want to put arbitrary limits.
Yeah, no, I agree. But thank you so much for your talk, your responses to the questions that we've had, and for really sharing your personal stories. It's been a fantastic health hour, and I feel really privileged to have hosted today. So thank you, Itunu.
Thank you for having me.
Back to Natasha from Cannes.
Hello all. It was a great session. It really was. I think the passion and the dedication for Black women's health and advocating, understanding our health needs regarding infertility was really felt in the room and felt online. I speak in behalf of the people on YouTube, on LinkedIn. We're receiving so many thank yous, and particularly for the sharing of personal stories. And yeah, it really is invaluable, the time that you both volunteered today. So thank you so much in behalf of those people, but also of Cannes. Dr. Itunu, is the first session that you've done of Health Hour. So we look forward to having you again. It really was very, very important, informative. I've learned loads, and I hear about women's health all the time, thanks to Cannes, which I'm very privileged to. So thank you. Let me just share my screen. As we know, Health Hour happens every Saturday. We are very focused on women's health this month. It was International Women's Day. I hope many of you that are on this call managed to attend our event last week, or even follow up what we have done online. There's certainly more pictures and videos to share from that day. So next week, we have focused on cervical cancer and everything that you need to know. The session again is at 11 a.m. Next Saturday is with Dr. Vaughn, and we'll be talking about all sorts of topics regarding cervical cancer prevention, treatment, and so on. In Cannes, we have very much a holistic approach to health, and we think that nutrition is very, very important. One of those medicines, natural medicine. So we're going to be talking about red meat versus white meat, which is a very common topic amongst people. So we're going to demystify some ideas around this and understand what might be best for yourself. So join us on Tuesday, 19th of March at 6:30. Again, free session with, obviously registered nutritionists and a physical instructor as well at the end. Cannes is in full force in London. We do have the London Inspire, which Cannes delivers on program health fair, again, completely free. And you will be able to have a series of health checks. This will be on Saturday, 20th of March. So there is a week to go from 10:30, Saturday, 20th of March. I don't think that's the right date, but it's this upcoming Saturday at 10:30 a.m. Do contact Bernice. I've left all the links, contact details on the chat just before I started presenting. So if you are looking to attend, yes, you can show up, but if you have any questions, do contact Bernice and go to this in-person event. We have a project as well called Healthy and Hearty with our partner, BHA. Is all about the Caribbean community and their heart health. So we're providing a series of services for people plus 40 in Manchester, so Moss Side, Rushells, Hume, Hardwick, Longside, Openshaw, and Clayton, regarding their heart health. Do contact us. As I said, details are on the chat. Now we're back in London, and we really are incentivizing everyone to check their email boxes. If you're between 55 and 74, living in the areas that are on the screen, there was a series of invites that were sent for lung health checks. So check your email boxes. Maybe you haven't received this information via email, and go get checked. Prevent any, lung illnesses, get screened, understand your health. So still in London, we are very proud to be delivering on the Black Health Inequality Summit this and next, not this Monday, the other one. So in about 9 days, this event is fully booked, so we are at capacity, but I hope some of you on this call will be attending. If you have not managed to sign up for the event, unfortunately, we'll still have online resources that we can provide. So I've left a form on the chat that you can sign up to receive these resources. But will be a great event that is 400 plus interested. So we're really, really excited for this event. Now, back in Manchester, in Gorton, Homes for Health is a project that is really focused on private tenants that may be facing challenges or faced in the past challenges and now want to advocate for with their housing conditions, maybe with their landlords, and particularly focus on the ways that this has affected your health. In any ways, could be, mold and lung health or mental health because you're unheard or other difficulties. So if you are Caribbean and African living in Gorton under a private tenancy, do reach out to us. Contacts are on the chat. And on the 27th of March, we are having an anti-racist awareness workshop. As I said, kind of as an holistic approach to health. And we very much focus as well on in being anti-racist in health and other areas. So if you are from Rochdale, you can join this workshop. Is designed for the voluntary sector, but also community, faith leaders, social enterprises, and even individuals that have interest in the area. Do sign up. It's contact is on the chat. And we spoke about, unfortunately, about loss in this health hour. CAN offers bereavement peer support group. We have a bereavement peer support group, is led by our counseling manager, Rosalind. Contact is on the list. You can see the dates as well on the flyer that are on the screen. But you can always reach out to Rosalind via email, and she'll try to help you as best as she can and refer you to the other counselors that we have within CAN. So I just want to thank you all for joining us. Zoom, YouTube, LinkedIn. The YouTube community is really growing. So shout out to you, and we will see you next week. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CAFIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.